morning I will be talking about medical management and therapeutic drug monitoring in IBD. It's just a little bit on myself. I'm an associate professor of medicine at the University of Chicago. I specialize in inflammatory bowel diseases, and I have a particular interest in women's health and preconception counseling and sexual health, as well as the pediatric to adult transition and treatment of J pouch inflammation. Here's the title. So the modern goals of IBD management, I think, are several, and they come sort of in phases. We start at the beginning with early and accurate diagnosis. So we want to clarify the phenotype. Where is the disease located? Because that's really going to matter in how we're going to target our therapy. We want to determine the prognosis, and we want to think about not just about what are the symptoms right now, and how severe are the symptoms the patient's having at this moment, but how severe do we think their whole disease course is? And what predictors do we have of someone that's going to potentially have a more mild course or a more severe course that would impact our decision on which medication is most appropriate. We also want to assess for extraintestinal manifestations such as joint pains, eye inflammation, skin conditions such as psoriasis, because a lot of our medications may overlap in treating those conditions, and we want to choose the best therapy that's going to sort of cover all the things that the patient's experiencing. So it's sort of important at the beginning to kind of take stock of all of these things when we're thinking about what we should do with therapy. We then want to induce remission. So that's turning off the inflammation. That's and foremost getting our patients to feel well. We set expectations with our patients that their expectation should be to be well. We don't want them to sort of settle and say, oh, I have IBD, so I'm going to have diarrhea. I'm going to have some symptoms. That's not what we want for them. Ideally, we want them to be well and be doing all the things that they want to do. We want normalization of their labs, their growth, their development, and adequate nutrition. Once they are well and we've established that they've healed and they're in remission, we want to make sure we're maintaining their remission. We want to make sure that their disease is continuing to be controlled, that their therapy is optimized if we need to adjust the dose, and that we're preventing relapses over time. Monitoring and prevention is important. We want to monitor for early or subclinical relapse. That's why it's really important that our patients see us regularly. I think sometimes patients are tempted to say, oh, they feel well, they just go on and live their lives, and they don't want to come and see us again. But it is really important that they're coming to see us regularly, so that even things that they may not know are necessarily related or not, they're reporting to us so we can kind of think through with them whether that might be an early symptom. We want to monitor their therapies. We're going to talk through all of our IBD therapies and what lab monitoring and other parameters are needed to keep our patients safe on their medication regimens. We want to prevent infections, make sure our patients are up to date with vaccines. Cancer prevention, we want to make sure that they're up to date with colorectal cancer surveillance, with skin survey if they're on a therapy that may increase the risk of a skin cancer. And we also want to consider the long-term consequences of chronic inflammation. We know that even if our patients are feeling well, if we're tolerating some inflammation, that untreated inflammation over time can lead to scar tissue and damage. And we want to make sure that we're managing that risk. So we want to assess the disease severity overall, and think about what predictors does a patient have for a more severe course, because that's really important when we're thinking about what we need to treat them with. There may be a patient whose symptoms wax and wane. Maybe they're okay at this moment, but we really need to think kind of about the big picture when we're counseling them on what's best for their treatment. So for ulcerative colitis patients, the patients that are low risk for colectomy are those that have a limited extent of disease and that have more mild disease when we look at it with a scope. The higher risk patients have more extensive disease, they have deeper ulcers, they're younger at diagnosis, they have high inflammatory markers, they've required steroids or hospitalization, and then they also have opportunistic infections. To some extent, we think C. diff infection and CMV infection are sort of markers of a sick colon that's vulnerable for those opportunistic things to take over. In Crohn's disease, the things that are lower risk are older age at diagnosis, more limited involvement no perianal disease, more superficial ulcers, no prior surgeries, no strictures, no penetrating behaviors like abscess or fistula. The higher risk patients are then sort of the opposite, the younger patients, the ones that have more bowel involved, that have perianal disease, that have had deep ulcers, that have had complications that have led to surgery. We also have to think about the risk factors of the overlapping immune conditions, mental health disorders. We know that our patients have high rates of anxiety and depression, disability, and the cumulative burden of inflammation. So we really need to think about who needs to be treated early and in what treatment is going to be best for them to address these things. Recall that what we're doing when we use medicines in IBD, right? We know that we don't know what causes Crohn's disease and ulcerative colitis, right? There's some combination of genetic risk and environmental triggers that trigger that overactive immune response. And since we're not smart enough to know what all those triggers are and turn them off so we can cure these diseases, our current medications are turning down the last step of that process, which is that immune overactivation. So we're not addressing underlying causes. We're turning down that immune response. And I explain this to my patients too as a way for them to understand why we're using these medicines, because they're worried about them and they need to understand why you would do it in order to feel like it's the right thing to do. And it's also important for patients to understand this because I think it helps them understand why they need to stay on medicines. It's hard for a 22-year-old to understand that they're going to need to be on a medicine indefinitely, even when they're feeling well. And so I use this to explain to them, we're putting the brakes on your immune system, we're holding it back. But if we take those brakes away, this whole process is going to start again because we don't know why it started. And we haven't taken that away. And that's why it's important that we have you on a medicine that's safe and not having side effects and that's keeping you well. So this is an overview of the medications that we're going to talk about more in detail for ulcerative colitis. Just as a way of introduction, the medications that we use for mild ulcerative colitis are mesalamine and steroids. Steroids are only ever to get people out of a crisis and to induce remission. They should never be a maintenance or long-term therapy. We should only be using them for the shortest time possible if necessary. And then for moderate to severe disease, we have several different biologic options, thankfully getting more and more, and some novel small molecules that we'll talk about in detail. For induction and remission in severe ulcerative colitis, some centers like ours, University of Chicago, we use things like cyclosporin or tacrolimus as well too. Crohn's disease, similar, a lot of our therapies overlap. However, mesalamine is actually not FDA-approved therapy for Crohn's disease. And so there'd be very few cases where that would be the appropriate medication for a Crohn's patient. So how do we choose the best therapy? So thinking about where is the inflammation, if this is an ulcerative colitis patient that has 5 centimeters of inflammation right in their rectum, it makes sense to use a medicine that's you're going to put right in their rectum, that's going right on their inflammation. If they have disease that's more diffuse throughout their bowel, you're going to want something that targets that. How severe is their inflammation? Is this mild disease that is maybe looks just like erythema or redness in the mucosal lining and has some aphthous or tiny little ulcers, or these really deep punched out ulcers? Do they have other inflammatory diseases? Do their joints really hurt every time they have a flare and they have joint inflammation? Do they have psoriasis? Have they had multiple episodes of uveitis? Are there safety concerns for this particular patient? Have they had a prior cancer diagnosis that they're under surveillance for? Are they especially prone to infections for some reason? Do they have cardiovascular disease, which would impact some of our medications? So we have to take into account all their other medical conditions. Are they willing to take the medicine? Some patients are going to say, I could never give myself a shot. I don't want to hear about shots. It's a non-starter for me. Others are going to say, I don't see myself going for infusions. It's going to be too hard to get there. My schedule's too busy. Some people are going to say, pill sounds great. I want a pill I can pop it every day. And others are going to say, I don't want to think about it every day. I only want to think about it every 8 weeks. And I go for my infusion. So patients have preferences that are really important. So shared decision making in terms of patients' priorities and preferences is a really important part of deciding what to go forward with. And then is the medication too expensive? Unfortunately, medication access is a reality of our healthcare system, and we have to make sure our patients can get the medicine, and they can get it at a cost that is going to be affordable and sustainable for their family, and that we're supporting them with any programs that are available to them. But unfortunately, we do need to take that into account in our decisions. So optimizing response to biologics in Crohn's disease. I think this is a very popular graphic to show in Crohn's disease therapy talks, but I think it's an important one to keep in mind that symptoms have periods of waxing and waning and flares and remission. That's this blue line here. But all along, the longer a patient has Crohn's, there's damage accumulating, and we need to, in treating early before that damage accumulates, is really important to getting patients well and keeping them well in the future. So we know that patients that have had disease for a shorter period of time and are treated with something like an anti-TNF respond better. They lose response less often. They have less surgery. It's important to treat early when we really have a chance to sort of impact the whole disease course. So we know, and we see that across all medications. This data is for anti-TNFs, but in almost every medication trial, we see that the first medicine works the best. The patients that are earlier in the disease course are more likely to respond. So we don't want to lose that really important opportunity to make an impact in the patient's disease course. Okay, so now we're going to go sort of medication class by medication class and talk about them a little bit more and sort of focus on what are the things we need to think about when we're seeing them in the office in terms of what should we be thinking about for monitoring, keeping patients safe on the medication. So azathioprine, or Imuran's the brand name, 6-mercaptopurine or pyranethol or methotrexate are immunosuppressants. Methotrexate can be given orally or injection. Azathioprine or 6-MP are oral. They're slow-acting medications. This is not a medication that we're going to use. None of these are things we're going to use to get out of a flare. They're going to be more long-term. They're going to help maintain remission. We used to use these more as sort of a primary monotherapy to keep our patients well. And now, since we have more targeted therapies with better safety profiles, such as the biologics, we use them less. We often use them in combination. There's combination therapy data for azathioprine, 6-MP, with anti-TNF medicines. We know that that helps boost anti-TNF levels and decrease antibodies. Likewise, the same for methotrexate. There's data that it helps boost adalimumab or infliximab levels and prevent antibodies. So oftentimes we're using it as a combination therapy. These are old medicines. They've been around for 50 years. However, they're not targeted to one particular immune therapy. They're not as fine-tuned as a biologic medicine. They're working more on that bone marrow level to really turn everything down. And with that comes additional safety risks. So we need to monitor these patients with blood tests and the dermatologist. So the test to order before starting, so for azathioprine and 6-MP, the enzyme that metabolizes these drugs is thiopurine methyltransferase, or TPMT, and there's variability in that enzyme's activity amongst patients, so you should check that, and that helps predict what dose they will go on. In young patients, you can check their EBV status to see if they've been previously exposed, because lymphoma risk is lower if they've previously been exposed to EBV. And then you need to check liver tests and blood counts. You need to check those at baseline, and they should be checked about every 12 weeks while patients are on therapy. We need to monitor the LFTs and CBC every 3 months. In our practice, we do that with refills as a way to keep track. We won't give people more than a 3-month supply, so that if they haven't come for their appointment and they're requesting a refill, we look back and say, oh, when were your last labs? You need to come in for some labs, and then you can have more of the medication. We know that there's an increased risk of basal cell and squamous cell skin cancers. And so it's important that these patients see a dermatologist to make sure that they're having a skin survey and then are having their skin evaluated at the appropriate intervals. This may also be associated with an increased risk of cervical dysplasia. And it's important that our women are having actually yearly cervical cancer screening, which is different than the general population, where it can be spread out based on risk factors. If patients are on immunosuppression, particularly ones like this, there's a higher risk. So we do need to, these medications can be used safely, but they do need the appropriate monitoring. Methotrexate cannot be used in pregnancy. However, azathioprine or 6-MP can be safely continued. Anti-TNF medications. So this is infliximab, adalimumab, certolizumab for Crohn's, or golimumab for ulcerative colitis. So anti-TNF medications are good when you need a medicine for quick induction. Infliximab patients can have response within the first dose. We often use that for our hospitalized patients that need quick induction. We have a long track record. Infliximab was approved in 1998. We know how to measure levels and adjust them. Consider these medications when we're thinking about those extraintestinal manifestations. So when we're thinking about patients with arthritis, uveitis, psoriasis, these medications can be effective for all of those conditions. So that can be a nice way to treat both. We need to monitor liver tests and blood counts before starting therapy. These patients need hepatitis B and TB testing because if they had dormant forms of either infection, they could become reactivated. In our practice, we check labs every 6 months for monitoring, and they have TB testing yearly. This could be a whole talk about anti-TNF therapy, but since we're not dedicating the whole talk to it, we will sort of leave it at that. We can adjust levels of the medication. Levels really vary a little bit on what the indication is. If for patients with more severe disease and perianal disease, we'd probably target a higher drug level than those without. So biosimilars, I've tried to focus a little bit on this talk about what's new in all of these areas. And what's new in the anti-TNF area are more biosimilars coming to market. So biosimilar is a medicine that has been shown to have no meaningful difference in safety, purity, or potency with a reference drug. So for a biologic medicine, the medicine is made by a living cell. So a different company can't make exactly the same drug as the originator because they're not going to have the same cell culture system, but they can make a drug that's equivalent in safety and potency. And so a lot of these have come to market for infliximab or adalimumab. And the hope is that it'll decrease cost for everyone, which would be a good thing if it helps us increase access. Things that are important to know is that if a patient develops anti-drug antibodies against the reference drug, those would cross-react with a biosimilar. So you can't switch between the originator and the biosimilar if there's anti-drug antibodies. The same drug level testing can be used for the originator and the biosimilar. So same sort of assay for monitoring for that. And switch between the originator and biosimilar is safe. That's been studied. It's okay to do that. We wouldn't expect loss of response or development of anti-drug antibodies. So here's a place that there are brand names, just so we can be sort of familiar with what the biosimilars are. For Remicade, the biosimilars you may hear about are Inflectra, Epsola, or Renflexis. For Humira, these have come to market really in the past year or so. Hiramas, Telzo, Amgevit, Hadlima, all these names that are very difficult to know how they came up with them. Most of them are not interchangeable, which means that they require the prescriber to write a new prescription for them. However, 2 of the Humira biosimilars are interchangeable, so they can be switched without a new prescription. I try to proactively talk to patients about biosimilars if I see that they're on infliximab or adalimumab, because it is a source of anxiety for them when they receive a letter in the mail telling them that the medication that's gotten them well and kept them well isn't covered anymore. So I try to tell them, I explain to them what a biosimilar is and how the safety and efficacy have been studied. I tell them I'm not worried about them switching to it, and that if that happened, that's okay. And I wouldn't expect it to flare their disease. So I try to be proactive in bringing that up because it is a source of concern sometimes for patients. New this year in anti-TNFs is injectable infliximab, so Zimfentra. So this is an option. The patients would still receive IV induction doses at week 0, 2, and 6, just as in traditional Remicade. And then there's a sub-Q injection that starts at week 10 of therapy and then every 2 weeks after. Or patients that have been on maintenance there could be switched. This is a sort of little schematic of what the drug levels look like. So the thought is that, with IV infliximab, you have this giant peak when you get a infusion, and then it sort of degrades over that 8 weeks between infusions. Whereas with an injection, you don't get to that giant peak right after the shot, but you have a more steady level. And so this is, something to think about. I know we have a lot of young patients that are traveling. They're going abroad. They're in college. They're going abroad. They're on an internship, or patients in general travel, and this is a nice option if it's somewhere where you can't continue their IV infusions, or there's patient preference, or there's patients where IV access becomes a real difficult issue over years. So it's a nice option to keep in mind. Okay, we're going to move on then to vedolizumab or Entyvio. This is an anti-integrin, so it is blocking the alpha-4 beta-7 integrin, which is what allows white blood cells to stick essentially to the intestinal tract. It is only FDA approved for ulcerative colitis and Crohn's disease because of its specificity to the immune response to the intestinal tract. The target for vedolizumab is only found in the intestinal tract and the nasopharynx. We've had it since 2014, so there's 10 years of post-marketing experience, and in that time frame, we have not seen that it increases the risk of infections or cancers. It's really a very safe therapy. It's not one that is going to see a huge difference with the first infusion. It's going to take a few infusions to work, which kind of makes sense if it's blocking more white blood cells from going to the intestine. It can't suck out the ones that are there already. Those are going to have to die out. So it's going to sort of block that new overactive immune response from occurring. So you kind of had to stay the course for the first couple infusions. That's okay. And I think it's important to set expectations with patients beforehand to tell them, it's going to take a few infusions to work, but then but then it really can result in good healing of the intestine and a good safety profile. This is just a little graphic of a white blood cell sticking. This is one of the areas that we have head-to-head data. So we don't have that much head-to-head data in IBD, but we do have this trial in ulcerative colitis of vedolizumab or Entyvio versus adalimumab or Humira in patients with moderate to severe ulcerative colitis. This is the Varsity trial. And you can see vedolizumab in red and adalimumab in blue. And you can see here that vedolizumab did have the edge a bit when we look at clinical remission and mucosal healing at week 52. So you can take that for what you will. I think that you need to remember that each patient is an individual, and there's not going to be one drug that's better for every ulcerative colitis patient. And we need to take into account sort of patient-specific variables. For the patient that has really bad arthritis and ulcerative colitis, vedolizumab is not going to be the best drug, and anti-TNF might be better for them. For a patient where it's really luminal disease and no extra intestinal manifestations, maybe vedolizumab is the best one. So I think, this is important data for us to have, but we also need to think about our patient's individual scenario when we're deciding on a therapy. Newest in vedolizumab is injectable. So an injectable formulation was approved for ulcerative colitis in October 2023, and just a few weeks ago, the injectable version of vedolizumab was approved for Crohn's. So in those patients that are new starts for vedolizumab, they have the option after the first 2 IV loading doses to switch to a sub-Q formulation every 2 weeks, or patients that are on maintenance therapy can switch as well too. So patients have the option of IV or injectable for vedolizumab. At this time, the IV infusion takes about 30 minutes. So again, patient preference in terms of what they feel is the best formulation for their lifestyle and to maintain adherence to the therapy. Okay. Moving on then to interleukin 12 and 23 blockers. So the interleukin 12 and 23 blocker that we have is ustekinumab or Stelara. We've had that for many years for Crohn's disease and ulcerative colitis. To review, that's given as a one-time IV infusion and then a shot every 8 weeks. More recently, we have risankizumab or Skyrizi, which has been approved for Crohn's since 2022, and actually just new in the past 2 weeks since these slides were originally made, is approval for ulcerative colitis. We also have a second anti-IL-23 mirikizumab or AMVO for ulcerative colitis. And we're going to talk a little bit more about these IL-23 therapies because they are newer, so we might be a little bit less familiar with them and their use. So Stelara or ustekinumab, is binding to a common subunit, the P40 subunit of IL-12 and 23, whereas the IL-23 specific medications are blocking to the P19 subunit, which is unique to IL-23. So there is some head-to-head data surrounding ustekinumab and Crohn's. We have two trials to look at when we're thinking about ustekinumab. So there was a head-to-head trial of ustekinumab versus adalimumab, so Stelara versus Humira, for moderate to severe Crohn's disease. That was called the CView trial. So that was a multi-center, randomized, double-blinded, parallel group controlled study. So interestingly, importantly, these were bio-naive patients. So this was a first therapy, and they had an ulcer of any size. And the patients were randomized to receive ustekinumab at the standard dosing or adalimumab. Interestingly, no one really won, if you will. They were both highly effective, though, which is interesting. They were actually more effective than most data for either agent usually is, and that might speak to the fact that these were bio-naive, early into their disease course patients. They had an ulcer of any size. So, how severe was their disease? So these are better results than we usually see with either drug, but they were about equivalent. And I think, again, that speaks to the fact that one drug is going to be right for some, the other might be right for others. There's no clear winner between these two. So I think, again, you're going to have to take into account some patient-specific factors, psoriasis, arthritis, those sorts of things are some things you could take into account in deciding on either or. We're going to talk a little bit more about risankizumab or Skyrizi. So this has a unique delivery mechanism. It's 3 IV infusions at week 0, 4, and 8. And then maintenance is with this on-body injector. So this is the only medication that we have that has this particular device. It can come in, the maintenance doses that are approved are either 180 or 360. So this little device has a sticker on the back that you then can stick to your stomach or your leg. You hit this gray button right over there, and it auto injects a needle for a subcutaneous injection, and then it goes in over several minutes. So it's kind of like a baby infusion of sorts that you give yourself at home. And it's just because there's too much volume to fit into a pen or syringe. So I have a demo of this in the clinics to show patients, because for some patients it feels a little bit less scary than something that looks like a shot or a pen. And so I do show them this when we're talking about it. The first injectable dose comes 4 weeks after the last infusion, and then the injections are every 8 weeks. So I only have the data here for Crohn's disease because the data for ulcerative colitis is so hot off the presses for this medication. But for risankizumab, it met its endpoints in Crohn's disease at week 12. So that's after the first 3 infusions and the first injection. So just keep in mind as patients are loading. In my practice, I've seen response sort of at that 8 to 12 week time point. It does take a little bit of time to work. So the first time points in the trial were week 12. So they met their endpoints for clinical remission, stool frequency and abdominal pain, as well as endoscopic response. You can see the co-primary endpoints here. Again, you can see that with previous biofailure or without previous biofailure, interestingly, it did do pretty well in patients that were biologic experienced. So inflammatory biomarkers through induction, you can see that there is certainly a drop at week 4. So that's that second infusion in terms of biomarkers, but there's sort of more improvement as you get out further, as with many of our therapies. Oops. So risankizumab versus ustekinumab. So what about if a patient had previously been on ustekinumab, which is IL-12/23, can you put them on an IL-23, or if they already failed that whole mechanism? So we knew from psoriasis that risankizumab was superior to ustekinumab in that setting. And in the induction trials for risankizumab for Crohn's disease, they actually needed more patients to be recruited, so they allowed 20% of the patients in that trial to be patients that had been previously exposed to ustekinumab. So we had some indication that, yeah, we can try it in patients that have been on ustekinumab. It's not, we don't have to sort of write off this whole class of medications. And because of this, there was a head-to-head trial called the sequence trial of risankizumab versus ustekinumab. So Skyrizi versus Stelara for Crohn's disease. It was an open label trial of moderate to severe Crohn's patients that had previously failed anti-TNF therapy. The investigators, even though the therapy was open label, the investigators were blinded to the clinical efficacy scores, and endoscopy was centrally read and blinded to treatment. So the people that were reading out the results were blinded to what they were on. So this is the superiority data. So risankizumab did meet superiority over ustekinumab for Crohn's. So this is endoscopic remission at week, level 2. Sensitive there, at week 48. And this is clinical remission. So it met superiority at week 48. So, you know, it is a consideration. It is a consideration for patients that perhaps have been on ustekinumab. You can try risankizumab, or when you're thinking about risankizumab versus ustekinumab, you may want to keep this data in mind, that there is some superiority data for risankizumab. Okay, mirikizumab for ulcerative colitis. So this is Omvo. This is another anti-IL-23 medication. This was approved in fall 2023. Recall now we have a second anti-IL-23 for ulcerative colitis, risankizumab. Mirikizumab is also given as 3 IV infusions 4 weeks apart. And then it's actually 2 shots every 4 weeks. So they don't have this on-body injector device for mirikizumab. Instead, it's 2 shots given every 4 weeks. So in the trials for mirikizumab, they did not allow previously exposed ustekinumab patients. So we don't have that same sort of data for ulcerative colitis that I just showed you for Crohn's, where we know whether patients that had previously been on Stelara would do well on this medication. So this is how the clinical trial, the LUCENT trial for mirikizumab was designed. And here's a little bit of the data. So the primary endpoints here of mirikizumab, it did meet its endpoints for clinical remission, clinical response, endoscopic remission, and the histologic endoscopic improvement. So here's kind of in thinking about the time frame, I think this is a really common question for patients to ask us is how quickly is this medication going to get me feeling better? What can I expect? And so you can kind of see here, this is remission of symptoms over weeks. You can see mirikizumab in yellow here. So recall that they're getting infusions at week 0, at week 4, week 8, and then first shots at week 12. So you can see at their getting to their second infusion, they're on their way up. It's getting better as you get to that third infusion, and then even a little bit better at week 12. So it does seem to take those first 3 infusions until they see sort of significant improvement. That's similarly when we're looking at bowel urgency. This trial, the LUCENT trial for mirikizumab was one of the first that really stressed the importance of bowel urgency as a really important symptom for our patients' quality of life and an important indicator if a drug is effective for them. And so that's something important to ask about in ulcerative colitis patients. How much urgency do they have? Are they worried about having an accident? Do they have to drop everything and run to the bathroom, or did they delay bowel movements? And if how long can they delay? So a really important thing when you're thinking about rectal healing and ulcerative colitis. And you can see it did take till about that third infusion or first injection for mirikizumab to take effect. Okay, so endpoints in maintenance therapy. So as we got into maintenance, we can see that mirikizumab met its endpoints as well. And so you can see that things stayed pretty stable as the change in bowel urgency. Once they sort of reached that improved score, it stayed pretty stable. It was a durable response. So safety for this medication, since it's newer for us, you can, oops, sorry. You can see in terms of serious adverse events, they really, there was not a signal that there were more serious adverse events with drug than with placebo. The things that were common were sort of things like nasopharyngitis. Ulcerative colitis was worse than the placebo than the drugs, things like headache, things that are common in the general population, but really no particular adverse effect really stood out from placebo. Administration, I went over a bit, 3 IV infusions, and then 2 shots every 4 weeks, 2 auto injector pens every 4 weeks. Okay, so monitoring for IL-23 therapy, again, a baseline CMP, CBC, hepatitis B, and TB testing. Check labs at the end of induction, that week 8 to 12 time point, and then every 4 to 6 weeks, we check a fecal calprotectin at about week 12 to see where patients are in terms of healing at that point. So the newer oral medicine, the small molecule inhibitors. So for Crohn's disease, we only have one small molecule inhibitor, upadacitinib or Rinvoq. For ulcerative colitis, we have 2 JAK inhibitors, tofacitinib or Xeljanz, as well as upadacitinib, and then we have 2 S1P receptor modulators, ozanimod or etrasimod, which are branded as Zeposia or Velsipity. So JAK inhibitors first, we're talking about tofacitinib and upadacitinib. These medicines, so what is JAK? JAK is Janus kinase. The Janus kinase enzymes, there's several of, there's JAK1, 2, and 3, and then there's TYK2, tyrosine kinase 2. These are signaling molecules, and you can see that, so they're up here. Here's the receptor for many different cytokines, right? You see IL-2, IL-4, IL-7, IL-9, IL-15, IL-21. So you can see many different interferon gamma. You can see all these different cytokines bind to the cell surface receptor, and then they're signaling through these Janus kinase enzymes. So by blocking the signaling molecule, you're blocking the pathway of many different immune pathways. So they are good for quick induction. They can actually help symptom improvement. I'll show you in the coming slides in the matter of days to weeks. The label mandates that they're used after an anti-TNF therapy, so we can't use them as a first-line therapy, and we're not currently using them in pregnancy. Pregnancy safety is not established. So that doesn't mean I don't use them ever in any young woman who can become pregnant. I'll talk to patients about what their plans for pregnancy are. First of all, it's really important patients don't become pregnant until they're in a stable remission. But I tell them, are you planning to become pregnant soon? If they say yes, as soon as I'm in remission, I want to become pregnant. Okay, then I would not start a JAK inhibitor because I'm not going to continue it during pregnancy. But if they say yes, that's a long-term goal for me in the next several years, I want to become pregnant, but not right now, not at this moment, then I say, okay, we can use this now. When it is that time, we should talk about it. We should reassess your remission. And at that point, reassess what data we have about pregnancy safety. And we may need to switch you to something that has established safety. But I wouldn't consider it never use in young women for that reason. So dosing for upadacitinib for Crohn's disease, it's 45 milligrams a day for 12 weeks for induction. Induction in ulcerative colitis is 8 weeks. And then after that induction, maintenance dosing can be 30 milligrams or 15 milligrams. You have to sort of assess the patient's disease severity to judge what the appropriate dose for them is. So in terms of induction or remission, this is the data from ulcerative colitis. And this is actually the day-by-day data. So this is days on medication. And you can see, and this again is about no bowel urgency. So the number of patients that had no bowel urgency was changing on sort of a day-by-day basis over the first 2 weeks. Similarly, the score of rectal bleeding and stool frequency was improving at the 2-week time point. So this is a pretty quick acting medication. For Crohn's disease, the induction period is week 12. Oops, sorry. So we can see that it met its endpoints for Crohn's disease at week 12, both in the patients that had previously failed other biologics, as well as those that were a mixture of bio-naive as well as bio-failure patients. Safety. So things that are important to think about for this class of medications is the higher risk of shingles. So our patients need to be vaccinated for shingles if they're going on these therapies. So The Shingrix vaccine is indicated for patients 19 and above who are on immunosuppression or who are going on immunosuppression. So our patients should be able to access this vaccine. So it's important to ask and give it to them. We give it to them in our GI clinic at University of Chicago. It's 2 shots. You get one and then you get the second 2 to 6 months later. So there is this blood clot risk data. So this comes from rheumatoid arthritis patients who were over 50 and had cardiovascular disease, and it was from the long-term oral surveillance study of tofacitinib. So this data is not particular to IBD patients that are young and don't have heart disease on upadacitinib. We don't have that data, but this is a black box warning on all of JAK inhibitors at this point. I discuss it with patients, but I tell them I'm not sure how it relates to them in particular because they were not the studied patient population. We do know that in active ulcerative colitis and Crohn's, there's a higher risk of blood clots in the setting of active inflammation, and treatment of inflammation actually decreases blood clot risk. So it's a little bit unclear what that risk looks like in our particular patients. These drugs can increase cholesterol, so it's important to check a baseline cholesterol panel before you're starting therapy and then at the end of induction and through maintenance. We do see acne with upadacitinib. Some have termed it JACNE, that in induction, there is more acne. We have used clindamycin 1% lotion with success in a lot of these patients, but I do warn patients ahead of time that that may happen. I mean, I have an 82-year-old, I'm like a teenager again. I have acne on my face, but he says it's a small price to pay for not feeling like he has partial obstructive symptoms for his Crohn's, and can take the clindamycin lotion for it. So something to discuss with your patients, keep an eye out for, and consider topical therapy to help treat them. Lab monitoring, kind of mentioned, liver test, blood counts, baseline cholesterol, shingles vaccination, and then monitor liver tests and blood counts and cholesterol at the end of induction and then periodically thereafter. S1P receptor modulators, so this is ozanimod or etrasimod. These medications are working by essentially blocking white blood cells from leaving lymph nodes. They are used in multiple sclerosis as well. Actually, ozanimod or Zeposia is used at the exact same dosing as we have for ulcerative colitis in multiple sclerosis. These medicines are only approved for ulcerative colitis. They are not approved for Crohn's disease. They're once daily oral medications. This is etrasimod's efficacy data. This is the newer of the 2 S1P receptor modulators. This is their data at the end of week 12 and at week 52. You can see it's about a 19.8% difference from placebo at week 12 and about 25% at week 52. Things to think about in particular about these medications, it does have a first dose heart rate reduction. In the clinical trials, there's an average of 1 beat per minute. However, because of that, patients do need a baseline ECG to make sure that they don't have heart block or cardiac conduction abnormalities. Macular edema risk is greater in patients that have diabetes or have had previous uveitis. And there is a risk of shingles as well, too. So these are things that we need to think about for monitoring. So you do not use these medicines if there's been a recent heart attack, stroke, or if there's heart block. You have to have a baseline EKG. Patients that have had uveitis or macular edema must have an eye exam before starting. So they need the exam before starting because they're the higher risk population. All patients on the medicine should have an eye exam close to start. If it's a little bit after they're starting, but they don't have any of these major risk factors, it's okay. Patients, again, should be vaccinated for shingles, and then you should monitor liver tests and blood counts through therapy. So this is a summary here. We have many different options for moderate to severe ulcerative colitis, as well as for Crohn's now. Pediatric therapy, steroids, mesalamine, and immunomodulators are used. The FDA-approved biologic options are infliximab or adalimumab. There has been published experience on using other biologics such as vedolizumab, ustekinumab, risankizumab, or the small molecules like tofacitinib, upadacitinib in the literature. However, those aren't FDA-approved indications at this point. We do use treat to target in inflammatory bowel disease. Low on time, so I'll just have a moment about it, that we assess disease, we assess patient symptomatic response, and then we look at objective markers of disease activity. If they're healed, then we move into a maintenance phase. If they're not healed, we adjust their therapy, and then we recheck those targets again until we've met our targets of both clinical remission, endoscopic healing as well. This has been studied in Crohn's disease, and we know when we change therapy to meet these targets, patients do better overall. How do we monitor disease activity? We monitor clinical symptoms, of course, but those are unreliable. Bowel symptoms can change because of stress, because of diet, because of other supplements, because of many things that are not their inflammation. So we can't always assume a new symptom is active inflammation. We have to check objective markers, physical findings like weight loss or fever, serum markers like CRP, albumin, platelets, imaging, CT, MRI, intestinal ultrasound, or endoscopy. So induction and maintenance therapies are chosen based on many factors, including the comorbid immune conditions or extraintestinal manifestations. In the absence of therapeutic biomarkers, treat to target is a good strategy. I set that out as an expectation with patients from the beginning, that this is how we're going to see if this drug is working. And you should make that plan with the patient and say, okay, you're going to come back at the end of induction. We're going to see how your symptoms are. We're going to check labs. We're going to check a fecal calprotectin. And then in 6 months, I'm going to do another scope. I'm going to do an intestinal ultrasound. I'm going to do something to see if your bowel's healed, just so that they know what they're looking for as well.